I wanted to have this scientific session presented in a way that everyone would go back to their office Monday and look at treatment planning a little differently, maybe with a more of a global view. And I think both Rick and Sir Winston really brought that home for us. I've listened to this now for many, many years, and even today I learned some things about how to look at a case. So it proves you're never too old to learn something. But the best way to learn it, obviously, is to look at cases. So the plan here is I've asked some people to come up and present a case or two and not say what they did, and then ask the group what you would do, how you would look at the case. And then we'll ask Sir Winston how he looks at the case. And then the presenter will show actually what he decided at the end and what they did. So I'm hoping that format will really bring home, just like TDO Clinical does, people can have an idea about something, but the only way really to test that idea is to look at individual cases and see if it passes muster. So I'm going to start, and then Charles Maupin is going to present, and then John Khademi, and then Luis, and then Pushpak, and then Carlos. There's no particular order, so first one that comes up, first serve. And we'll try and get through this. I'd like to actually finish early if we could. The vendors are upset that we didn't have a break this morning, and since they support this, we do have to have a break so that you can go and spend money and take a look at their products. And the scientific session depends on income from those vendors, so it's very important for us that you utilize the vendors and make them feel welcome here. So let me do one case real quickly, and then we'll go to Charles. So this was a patient that came in to me. He's a PhD student at Cal Poly in structural engineering, and he came from a periodontist asking me to retreat a tooth and then send back to him for some periodontal grafting and laser treatment. So this is the case. The tooth is completely asymptomatic, but not very attractive. And I'm going to show you what the final report looks like that's generated from our software, because this is really about the first real test on our software. So the data is collected about the case, and then the final case, the summary, is printed from that. So the patient's name, age, sex, marital status, and ethnicity. The chief complaint: why is the patient in the office? I want my front tooth fixed. I hate the way it looks. Their dental expectations, when I asked him what did he expect, he said, I don't want to do a temporary fix and would like the most predictable long-term solution. The lifestyle: he's a graduate student at Cal Poly and structural engineer. There's no history of drug or alcohol or smoking, normal weight. He has good vitals. Both parents are alive and healthy. They have a Chinese restaurant, so you probably know they work about 18 hours a day. The patient was referred by a periodontist that requested a retreatment of the tooth, after which he will do laser and bone grafting. I don't know the periodontist. I don't know the GP. The patient is currently in the last stage of orthodontic treatment. So these are the findings on the extraoral exam. Sir Winston can go over why these things are important if he thinks it's appropriate for us to do, but this is collected much in the same way that TDO data is collected, contemporaneously as you are examining the patient. And there's nothing here that is really contraindicating an implant as far as I can see. So you make these measurements, and the treatment constraints on this patient are that he's a full-time student. He seemed to me, he's failed several appointments with me, and he has limited financial resources. These are the results of the dental exam. Nothing really stands out there. He's had minimal dentistry. He only has 3 fillings in his whole mouth, so he's not losing teeth from caries or periodontal disease. The intraoral exam was also very nondescript. You measure the tongue, the arch form, the tori, salivary flow, frenum attachments, and floor of the mouth. And then this is the case. Let me reduce it a little bit here. So looking at the radiograph, you can see there's some cratering on the lingual. When you look at the tooth, it looks to me like this was perhaps a traumatic accident when he was younger. He said the endo was done 15 years ago. So from a diagnostic point of view, I don't really know why that tooth is pushed out like that. It's not an occlusal trauma. I don't know if there's a tongue thrusting issue here or why it is like that or why he has this periodontal pocket. He has 7 millimeter probings around the cratering on the lingual. The tooth is completely asymptomatic. It's not mobile. Those are the probings, and this is the CT. So let's see if there's another. Yeah, there's a better CT of what the bone pattern looks like. So I have a decision here: do nothing, do the retreatment, or recommend an implant. And I am conflicted simply because of the bone pattern on the lingual and on the buccal. There aren't any aesthetic issues. I'll show you. This is the lower arch. That's the diagnosis page. That's the lingual pocketing. So not knowing the periodontist or not knowing that much about periodontist, I don't know what kind of bone grafting he's talking about or what kind of laser treatment he's talking about. A call into the periodontist did not elicit a return call. This is what he looks like with a smile. This is an angled view. And these were the soundings. I did soundings around it. It went down to 7 millimeters. So I'm conflicted. I don't really know, given what his chief complaint was and what the treatment complexities are, and that he wanted the most predictable thing. I'm a little conflicted on whether I really want to take this dentistry apart and whether that's really the right thing for the patient. So I'll put it out to you, and then I'd like to see how Sir Winston evaluates the case. Any ideas? Who would retreat this? And when we have the questions, we can turn the lights up so I can see. There's no mobility, and it's completely asymptomatic. He did have pus coming out of the lingual sulcus of the tooth, and his chief complaint is he simply wants to look better. And you have a request from the periodontist that wants some pretty, in my office, that's a $2,500 retreat. And before I do that, I want to make sure that our expectations are aligned with each other, because I don't think the retreatment on this case is going to really solve the real problem that he has. So, any ideas here? It was a complete crater all the way around, 7 millimeters all the way around on the lingual. So fortunately, I don't think there are the aesthetic issues here that, but I guess my question is this patient better off with an implant? And then what are the issues with an implant here? Because this is not an ideal implant site here. Yes?
Gary, I see brackets on the bottom there. How far along is he in ortho? How long will those?
You know, I don't know. He said the orthodontist was going to take the bands off, I think, within several months.
So we don't know that tooth. Your report is it's not in traumatic occlusion now.
That's correct. I don't know what it was previously. I'm suspicious of a tongue thrusting habit here, but I don't have much experience with the tongue thrusting habit and what kind of issues those present. Anyway, so let me just take a vote because I don't want to take up too much other people's times. How many here would retreat this knowing what you know about this now? How many would retreat it? Nobody?
Yeah, of course. I think it's well, let's.
This is known as the Amsterdam model. But there's something in the water in Amsterdam. Okay, two. And the reason, and your reason. Let me listen to your reasoning, your decision-making reasoning.
We put a little nuance in. I would just start taking apart, make a temporary crown, see what's underneath. I want to have a little bit more information before I decide to have it extracted. Yeah.
Well, to have it extracted, though, you have to have good feelings about the implant. Now, it turns out that I sent this patient. This is one of these ones where Sir Winston says, I commandeered the patient. And I said, I want you, before we make any decision, I want you to get on to Peter Shaw, and I want him to take a look at this to make sure that an implant is even a possibility here. And he went down to see Peter, and Peter doesn't want to do the implant. Okay?
Yeah, I would put it in a provisional, send it back to Perio to get it under control, and then just.
I think Peter was talking about extruding the tooth, orthodontically extruding it, which was something I didn't think about and probably should have thought about. Was there only 2 people that would retreat this?
After Winston Chee, yeah.
Yeah, when are you gonna fix?
Is there a fourth option of doing just the video?
Yeah.
Just doing the bone graft and the laser treatment. Huh? Well, the patient's complaint is that he doesn't like the way it looks, so the periodontist is probably trying to cover all his bases here, doesn't want to go all the way through this and then realize there's an endodontic issue with the post, or maybe even wants the post out of there for a reason. If you might even make a case that there's some lateral canal high off on the post because the post it looks like there's problems in the post. So he wants to get all of the possible endodontic issues out of the way before he goes through his thing. That's probably what he's thinking. How many would put the, Peggy?
He has tons of subgingival calculus. That's where that suppuration is probably coming from. He needs good initial preparation, scaling and replaning under local anesthesia to get that under control. And then he doesn't have any money now, so maybe just remove that crown, remove any recurrent caries that's around there, and talk him into something, maybe a little temporary, but it might be temporary for a long time if you get that perio under control.
I don't see tons of subgingival calculus. Am I missing something here?
Take a look at that lingual clinical photo. that tissue was really inflamed. I mean, any hygienist looking at that would say, oh my goodness, like to get a curette under there.
There's
See that?
barnacles on that root, man.
I don't think so. It looked like a root that had been scraped to hell and he had lost attachment there.
But the tissue, especially on the palatal, should look a lot better if they knew what they were doing.
You know, he's only had 3 restorations. His mouth was pretty clean.
Yeah, but he's got a 7mm pocket, and it's wide.
It's not a 7mm pocket, it's a 7mm crater. How many would just take it out and do the implant? No? Okay. Okay, Sir Winston, you got a shot at this. How should we be thinking about this?
Well, you know, instead of deciding what you want to do, I mean, the question is to figure out, you have to be a little bit of a detective and try and figure out, you know, why, you know, what is the cause of this isolated thing. So it's unlikely that it's systemic. So it's not generalized. So it's probably localized, and if there's no anomaly on the root that Gary has detected while feeling it, then it's likely to have been trauma a long time ago. So if it's trauma a long time ago, these things are not amenable to any kind of surgery. So I don't know what the periodontist is thinking about. Must be smoking dope or something. Because this peak here is attachment and attachment. No matter what you do here, you can cut all you want, it's going to come back. He has a laser. I have the box of a laser that I put in the practice just to impress my patients. So if anybody buys a laser, ask them for the box and then just put it there. There is no efficacy that I know of for lasers, but there is a lot of efficacy for the box that the laser came in. Anyway, so I think it doesn't seem to be an endo problem. It could be excessive canal or crack on the root. When we treatment plan, we don't. The guy has financial constraints, but my advice is, don't think about that. Just think about what's best and then present it to the patient, and you'll be surprised, right? I mean, maybe for one tooth it's not that big a deal, but we do that for the reconstructions. And the guy that comes in the Jaguar might not pay for it, but the teacher with the Honda Accord will understand the value of your treatment and go for it. So I learned that actually from my program director, Jack Preston, and he was right. 30 years later in my career, he's right. The people you least think will go for it will go for it. So put money aside, okay? So yeah, so what I would do is, since the implant is not an option yet, and there's no root anomaly, and you got to do something about that periodontal defect. Peggy may be correct that this there is calculus there. If you have shitty hygienists in an office, what happens is they burnish the calculus instead of grabbing it and cleaning the root, and then it becomes much harder for the hygienist to take care of, because it's just like burnished against the root. If you look at can you go back to the lateral, the CT where you can see the bony plate? You'll see that is cortical bone, so this is long standing. It's not so even if it's blown up recently, and he has an acute episode, you can see that. It's not all eaten up, and it doesn't look like it's rapidly progressing. It's probably had trauma, and then it's gone back and forth with episodes of chronic disease. But again, it's just a guess. There's probably calculus there. So a forced eruption is not a bad idea, and it's something that I would consider. Again, you have to look at the root morphology from the straight on view, which is here, and you can see the root is not severely tapering or anything. So when you erupt it, you can still make the tooth look decent. And then when you erupt it, you kind of level off the bone, but the periodontist now has to go in without the laser, raise a flap, because some of the bone is going to come with it. You want the lingual bone to come with it, but the interproximal bone will also come with it. You're going to create 2 vertical defects there. You have to correct that and then harmonize the area. Then at that point, you could to deconstruct the restoration and see what it looks like, whether you think there's an issue with the post. If the post is stable and you don't see any leakage or decay around it, I would let sleeping dogs lie, and then I would put a new restoration on it. But the issue here is not endo, is that defect on the lingual that a laser is not going to solve. So, I mean, step by step, that's what we'll do. And again, that in itself may be a risk. I mean, Peter Shaw may not want to place the implant, but if you look at the attachment on the adjacent teeth, and this patient has fairly thick tissue, that would not bother us at all as far as getting an implant in there. So, but then an implant on this particular patient is a couple of steps off, because if this tooth fails, what's going to fail with it? Just the tooth. It's not going to affect the adjacent tooth. It's not going to affect the reconstruction. So this is a tooth where you can provide some treatment, and yeah, it may cost the patient some money, but as a safety issue, if the pocket can be managed, the area can be kept clean, putting a crown on it, it's the safest thing you can do. So, I mean, that's the thought process that we would go through. If this were part of a key reconstruction, the same tooth, the same presentation, the story would be different. That's why you have to ask the question. Now, the good thing about what Gary did is that he has extra oral shots and he's looking at that, and right from the get-go, he's saying that, the lip dynamics are not going to be an issue here, and so we don't really care what the cervical part looks like. We're just concerned about mostly the 75% of the clinical crown, and then that some of the limitations are taken off. It's not a super duper aesthetic kind of situation. I mean that it's.
Hey, Gary, one of the things with a tooth like this that you may want to also tell the patient is sometimes these teeth extrude over time. They're fine now at incisor levels, and then a year or 2, 3 down the line with a new crown, suddenly the tooth has superaddupted slightly because it just doesn't have a great foundation. And that might, considering his chief complaint, that will completely, be an accident.
Okay, Charles,
I have seen some cases where there is corneal leakage. Usually, when you look under the microscope, we feel like the bacteria is totally infiltrating the root structure up to the. So we find a juices like this, and I don't find any cracks or something like that. So mostly, I'm thinking about the bacteria getting all the way through everything, and if for some reason we have lost cementum in this area, we can have that juices. So my thinking that regarding that we are going to, this crown has to be removed anyway. We can remove the crown, can check the coronal leakage, and if there is something like that, we will remove the post on top.
Yeah, I guess my thinking was subjecting the patient to a $2,500 bill without really solving his main problem, which is that lingual pocket. I don't know. I think just listening to what I'm listening, I'd rather send him to the periodontist, say, do your laser and bone grafting, and if all that works, then I'll take the dentistry apart if we need to. Well, pardon? So what you do? I haven't decided yet. That's why I brought the case. Yeah. Okay, Charles, you want to come up? Yeah. I've called the periodontist twice, and because I was interested in, maybe there's something I don't know about the laser treatment, or what do they call them, apically repositioned flaps or something that he was planning. I don't know. Okay. This is Charles Maupin. Most of you know him from TDO Clinical. He's one of the finest endodontists I've ever seen, and he's actually turned into a pretty damn good implantologist too. So, your game.
Thanks, Gary. Like most here, run a fast-paced practice, putting out a couple fires a day, attending to staff and everything. And when Gary asked me to do this, I thought it'd be pretty easy to get a case or two, but what I've realized is that my workups need vast improvement. And I think as endodontists, we've kind of dug our own hole, and as Winston said, kind of, being removed from the treatment planning. And I think we can all kind of take a step back and do a little better job and help kind of right the ship on that. Okay, so this is patient 1, 57-year-old Hispanic male. He's a plant tech for an oil field company, lifestyle, married with 2 children. His chief complaint, he was referred to me as chief complaint, was my crown keeps falling off. His daughter's getting married in 2 months, and he would like to be able to smile for the wedding pictures. And he was referred for an implant. His dental expectations are, Gilbert, like I said, was referred for an implant in side 8. He's concerned about his upcoming daughter's wedding, and he'd like to be able to smile. Treatment constraints are none. He's healthy. Extraoral and intraoral exams are non-contributory, and he's occlusion class 1. Testing. His phenotype, he has thick biotype, papillae flat, and the smile line is pretty low. So treatment plan 1, he was referred for an implant. So implant, custom abutment, and crown was first treatment plan, and just looking at it. Treatment plan 2 was to deconstruct, possibly cast post and core, and a crown. Clinical photo. So again, you can see the thick biotype, flat papillae. Not many other restorations going on. And here's how the tooth presented, the PA. The crown and post were cemented on there with temporary cement. So after Gilbert and I reviewed everything, what we decided was to remove the crown and then kind of evaluate from there. But this is how we presented, so we'll kind of open it up now. And here's a cone beam. So any thoughts on how to proceed? He's asymptomatic.
Are the crown and post one unit, or does the crown come off the post?
The post is in there, temporarily cemented, and then the crown is on top of the buildup. So, but it can all come out.
Over here.
Yes.
Amsterdam. His main concern is the aesthetics for the wedding, and I don't think it's only the crown that's bothering him, but also all the discoloration in his tooth. So one of the first things I would probably do is have some bleaching trays made for him. Because by the time you have made a decision deconstructing the crown, there's not enough time to bleach the teeth.
He did not say anything about the staining, discoloration of his teeth being a problem to him. So, he's lived like that for quite a while. A lot of people in West Texas, where I'm at, high fluoride wells, I see this quite a bit. So to him, that was not an issue.
I would remove the crown and see what is the reason that it fell so
I would put some stain on the crown.
Yes. Rob. So here's what it looks like with the crown and post removed.
I think there's enough tooth there.
I think you can make it last a couple weeks till his wedding's over.
I will say, we'll throw this out there. He wants it to look good, like I said, for his daughter's wedding, but he doesn't want to do something, temporary for short term either. So he wants to do something for the long term, but he also wants a good result aesthetically.
Charles, do you have a picture of it with the occlusion in place with the lower teeth?
I do not. Again, this is where I've been lacking in a lot of that and need to slow down and take time to do something.
How much of an overbite is it?
I guess I do have that picture. A couple millimeters.
Is there any fremitus at all?
None that I noted. Yes, it has come off twice, and so his dentist was kind of tired of messing with it and wanted to pass the buck, and so he referred him for an implant.
If it's come off twice already, how many times are we going to put the crown back on? It's going to keep coming off. At some point, isn't it just
non-restorable, and that's when we move on to the next step?
Yeah, that's what, I mean, so options are implant, or, you know, do we want to try to build it up again?
Charles, just out of curiosity, why don't you ask for a vote?
How many would retreat and restore? And how many would remove and place an implant? How many would do nothing? Bridge? Yeah. He has a low smile line. Yeah, right, low smile line. He doesn't show it. You know, I think Winston. I think there's more reach. I think there's more on the save versus the extract. But I think Winston has kind of driven home that, you know, with the single tooth, we don't have as much at stake. I will say that I do see a lot, and you may not see it in practice, I see a lot of teeth unnecessarily being recommended removal or just plain removed and replaced for implants. And I think that's an issue that we all see. But I'll show you what I did on this one. So the treatment on this one was we removed it.
Before you go ahead, I mean, this tooth with that amount of circumferential tooth structure and all the posterior units in contact and just one tooth is nowhere near ready for extraction. So you have to understand that, again, if something is going to fail and fail by itself, you know, go ahead and take a chance. I mean, in my own mouth, I had a squash bracket in my face. I have a lateral incisor that's fractured. I don't even remember what it looked like. I wasn't even a dentist then. And it's still in my mouth. But there wasn't much of a tooth left, if I remember, from when I looked in the mirror. So I have all the rest of my teeth. This is a shallow incisal guidance. Whoever asked about the occlusal function, that was a good question. If you look at all these other teeth, there's somewhere, but it's appropriate for the age of the patient. So you need to have all these questions. Is it a high function patient? Why is the patient here? Is this isolated or is it generalized? I mean, you need to go through all those questions instead of, what am I going to do now? Will you take it out or put it in? You can't do that. You have to go through the process. And then, if this tooth fails, what is going to happen? If this tooth fails, is it going to affect the attachment on either side of the teeth? Because that's the critical thing for when you eventually place an implant, you know, for aesthetics. And yeah, the lower lip, the lip is low, but still, you know, why don't you just train yourself to look at all factors, and then after that you can disregard the lip. But if you learn to think systematically, then that would really help. But I can tell you that as aggressive as you think I am removing teeth, I'm not placing any implants in the area with a single tooth. It's nowhere close, because when you look at the occlusal shot, there's a nice ring of dentin around that. So you can do a little crown lengthening if you're nervous. You can erupt the tooth if you get fancy. But I would check the seal. The post is out. Check the seal. The seal is good. Let's put another post in and restore it.
So that's what we did. Cleaned it out, didn't retreat it. It looked fine on the CT. Cast post and core. And then I don't get to do it very often, but I restored this case. And image on the left is the crown. And this is a 3-year recall.
And take it out of the lateral exclusion. All these other teeth, you can just grind off the lingual or even grind the mandibular teeth. Just take it out of exclusion.
This is Nick, 56-year-old Caucasian male, spiritual care coordinator, married. He's neglected his treatment for the past 15 years, and he's now ready to take care of it. Nick does have some concerns about finances, but he would like to do what's best. So we're looking at the lower right quadrant and the upper left, 231/30 previously treated. And he's having pain right now in the upper left quadrant. Tissue phenotype, thick, flat, low smile line. can't see he has some occlusal wear. Here's the pano, silver points on 30 and 31, large decay on 13, 14, and 15. 18 has decay as well. PAs. So I'll open it up now. Treatment. Right. I think 30 and 31 are pretty easy. Remove those. How about 13, 14, and 15? Bite wing. Who'd save 13? Who would?
Again, don't make the decision based on the truth. Make the decision based on the etiology, the patient's susceptibility to disease, and the whole segment. Do yourself a favor and start thinking that way. Don't take it apart and look tooth by tooth. After you look at everything collectively, then you can look at it tooth by tooth and decide whether this segment, in your opinion, is going to be more stable, restored with implants, or treating the infections and restoring teeth. So you're going to take everything off, look at the amount of tooth structure, together with the etiology, together with the patient's susceptibility to decay. Of course, you're going to prescribe fluoride and everything else to mitigate the problem he has, and then make your decision.
Charles, some of these are tough to prognosticate, because if you have a patient who says, I haven't been in for 15 years, is this just some slow stuff that's just been creeping up for 15 years? Or does he really have a condition that's causing all this decay? Because there's a lot of decay.
Right.
But if it was a couple little spots 15 years ago and it's just been growing, well, then maybe he doesn't have as bad of a decay problem as we might think.
In looking all over, he's got a couple quadrants that have a lot of decay, but in general, he doesn't have rampant decay going on for 15 years of neglect.
The concern as well, going back to what Winston said, is he prepared for long-term maintenance and the financial investment and the time investment in the next 40 years of his life? Or does he say he wants to get things sorted now and can he go back to maintenance, long-term maintenance of patients? All things being equal.
Let me ask you a question. If a patient is caries susceptible, that is different than a periodontal model, right? But a caries is patient susceptible, and you need calcified tissue to get decay. What happens when you put titanium in there? The problem is solved. Okay, it's different than periodontal disease. In periodontal disease, you can say that the patient has overreaction to any excessive inflammatory reaction to any insult. So you remove the tooth, you place the implant, they still have this excessive reaction to any insult, which can happen around the implant. So on those patients, you have to be a little bit more careful. But if the patient is breaking down due to decay, the question is, do you feel confident that he can treat that quadrant one time and not 2 times? And if it's one time, where do you lean, toward implants or toward teeth? Sounds terrible, but that's the cold hard fact. And you can think about it, but that's just the situation. And also anatomically, the sinuses and everything are nowhere near. Right? Anatomically, there are no extra procedures that can interfere with your process. So you have to start thinking that way, and then the decision making becomes a little bit more clear.
Winston, how much bone are we looking at here to make put 2 implants in that area? Particularly, what's the minimum bone level here?
Oh, here you have 1 ton of bone. So look at the level of the sinus is up there somewhere. It's not imaginating these teeth or anything. You do a careful extraction, which I must say, the endodontists who are placing implants are doing a marvelous job. They do it under a microscope and they section the teeth and just collapse them in almost the whole socket is there. There's absolutely no need for a bone graft because you get a nice big fat clot there. So you're going to, I don't have any issues here. I'm sure Charles will have no issues here with the amount or depth of bone. And the width of bone back there, I don't think is an issue either. I mean, I don't see a blowout on any of those buccal or lingual walls. So I think you're good to go here if you want to place an implant. If you want to restore these teeth and there's enough tooth structure, if you want to do that, you can do that. But again, you want to think about all the cases I showed and what is this going to look like 5 to 10 years from now. There's a significant amount of money, 3 endos, 3 foundation restorations, and 2 crowns. It's not a small amount of money. It's not a small amount of money. Right? And then you are at the mercy. Okay, one good thing about endo, when you do repair teeth, you're at the mercy of the quality of my restorative treatment, right? If you put an implant in there's almost nothing I can do that's going to screw up anything. So you can work with almost, you can work with no cement. If you don't cement, there's almost nothing I can do that's going to impact the implant, right? So, you don't need any dexterity. Right? And let me tell you, the oral surgeon's model for treatment of implants is very much like what Rick is doing for endo. They place the implant, they put a scan body on the implant, they scan it, they send the digital stuff out to the lab, and then the restoration comes in the little box of the dentist puts it in the mouth. So in oral surgeon's practice for implants, all the referral group are just collecting patients. He doesn't want them to think, he doesn't want them to do nothing. He does everything. He chooses the lab. Some of them even pay the lab bill. That's business.
So I think, being involved in implants has enabled me to see this case type here, though. Otherwise, I don't think I would see this case type. But what we did for treatment, these were the treatment plans. Alternatives. But we treated 13 and 14, 15 endodontically, restored them, cores. Implants in 30 and 31. 30-month recalls in the upper left and 2-year recalls in the lower right. I take blame for the restorations on the implants. I didn't set them up right. Now I do exactly as Winston said. I scan everything with the iTero, the file's sent over, and they have it back, and it's pretty much it's easy for them to restore. These were just stock abutments on there.
When you collect these cases, they're great. You should present back to TDO in 10, 15 years with this section with implants and the other section with endodontic teeth. And I suspect you have very similar experiences as I had over the last 30 years.
So does this guy like drink Coke all day, or is there anything you could?
Nothing that I could pinpoint. He had moved back to Lubbock he lived out here in California, and he said he had some rough times and a lot of stress, but we could never pinpoint anything particular that was causing that. I believe his restorative dentist did. I didn't do that per se. I think we'll just skip over this case. We've kind of hit the single tooth model, but high smile line, single tooth. I think we're willing to play a little more on the single tooth, but we saved it in a 3-year recall. And lastly, we'll go over this case here. So again, involvement in implants has enabled me to see this case type, and this restorative dentist came to me kind of wanting to help treatment planning. This guy here, close-up photo. So he has active periodontal disease going on. And so he was wanting to know which teeth we should save, which teeth we should extract. And then this guy was undergoing full mouth rehabilitation, and he was wanting to know thoughts on 19 and 30 area implants versus bridges. And the RD was leaning, he had been missing those teeth for quite some time. He didn't think there were enough bone for implants, and so he was leaning towards bridges. So we kind of talked about, like Rick mentioned earlier, problems of bridge, 5 to 7, those abutment teeth are 5 to 7 more times likely to need treatment further on versus implants. So I guess any thoughts on, this is similar to Winston's case that he showed earlier. Should we try to save 8, save 9? Winston?
It's just hard to tell from history, but is that just circumferential? The number 8?
Right, yes. I don't know if that helps some. He had pocketing mobility of 7, 8, 9, and 10. He's got some attachment loss on the mesial of 6 and 11 as well.
Yeah. Well, it would be better to look at it with some periodicals and look at the mobility, and then also what the overall treatment plan is for the rest of the mouth. But certainly, if they are really severely involved periodontally, you want to you gotta look at if 6 and 11 are in good shape, then you want to treat 7, 8, 9, 10 as a second. And then you just have to make a decision whether it's going to be implant supported or tooth-fork. And if it's implant supported, then the preferred place to place the implants is 7 and 10 or 7 and 9. To keep the implants as far away from each other. But if you need teeth to transition the patient with a provisional, then sometimes you have to put them in 8 and 9. But you have to wait quite a while for the healing of the area, and number 8 may not have a great implant site because of the extensive tension of the area. So you might even extricate the top on number 8, and if it's stable enough, use it to hold the provisional, and then decide what other site you want for an implant, and not use the 8 implant site. That would be, that's if you're just looking at this area. But again, the thing should be treatment planned comprehensively throughout the mouth as far as the periodontal disease and everything else. So it's just hard to tell. Like I told Gary during lunch, it's likely that I'll be saying not enough information for many of these patients. So again, endodontists have to get away from treating by prescription, putting on the rubber dam and treating the tooth. Get to be part of the team, look at the mouth, try and find out everything, and then be a participant in the discussion of everything else.
So what we did on this, 7 through 10 were removed, and 6 and 11, we weren't sure of the long-term prognosis, but we removed 7 through 10, had them in a flipper, and they seemed to be stable long-term. We opted for implants in the 8 and 9 position. Should 6 and 11 ever have an issue, then we can come and put implants there, do a 6x8 and 9x11 as needed. And then implants in the 19 and 30 position. So I placed the implants, let them heal, came back with a screw retain provisional, and then that's provisional in his smile line, and his before and after, and like Winston said, everything was scanned and sent over. And that's all I have. So, John?
All right. My patients are a little older, so the workups and the imaging are not quite as good. Lynn is now a 62-year-old female. She has a clinical practice in psychology, therapy, that kind of thing, so she's crazy. And I saw her first in 2003. Her complaint was some tenderness down in this general area here, and I thought it was a food impaction problem. The endo had been done sometime before, not by me, but by a BU grad. You know I'm going to do that. And then we saw, whoops, I didn't want to get ahead. We saw her back to reevaluate the area about a week or so later, and by then she'd actually developed a sinus tract on the buccal of tooth number 28. So what do you think we should do?
Do you trace it?
No, it's pointless. We've had that discussion. Pardon? Not in 2003, I don't. It's okay, we don't have to answer it now. Buckle of the affected tooth, buckle of the treated tooth. Pardon? I couldn't probe her at the consultation visit, she was too sore. What are you thinking? Pardon? Yeah, it's 2003, buddy. No CT. No CT then. Okay. So angled radiograph. Well, that is kind of angled. That's the angle. Actually, I have a piece of scanned film that there's no evidence of another canal in the tooth. So, anybody want to retreat it?
The other teeth are okay.
Yeah, I got a pan on her, and she's basically got a full dentition. So we're calling this a single tooth problem. Pardon? Other teeth are vital, yeah. Tests as expected. We just got a little buckle bump in the 28 area.
How long after the initial treatment?
Some years. Yeah, not some decades, some years. In 2003, okay, she's got a full dentition. She's not missing any teeth. So, okay, let's go to the next one because we're gonna answer all of these because I have follow-ups on all of these. Some time goes by, and I see her in 2005, and now she has a complaint by this upper molar. She's got a buccal sinus tract and a probing in that area as well. I don't have the history on that tooth other than the endo was done some years ago, and I know now that some years ago is actually some years, it's not some decades. And the endo on the bicuspid is also done some years ago as well. So we stumble across the bicuspid as an incidental finding. She's completely asymptomatic on the bicuspid. The molar is lightly symptomatic as you'd expect it to be with, buccal sinus tract and probing on the buccal. Anybody want to redo the apico? What you can't see on that angle, again, this is a piece of scanned film from the restorative dent. Actually, this one's from the periodontist. It's a DB root amp. This ended up as a DB root amp. This is a very sad tale on this poor lady. Who wants to retreat? I mean, there's obvious pathology, right, on the bicuspid. Who wants to retreat the bi? I mean, you guys know where this headed because I hold all the cards. Who wants to retreat the bi? All right, some time goes by. Again, she comes back. It's 2006. She's got a little tenderness down here, a little complaint to biting sensitivity since the beginning of the year, so 6 months. The root canal was done years ago. Anybody want to read? I mean, part of her complaint on this tooth was acute gutta-percha insufficiency. I mean, you guys have read the standard of contemporary practice, right? Lower molar with prior endodontic therapy does not meet the standards of contemporary practice. She's got gutta-percha insufficiency. We got to cure her of it. Acute. Her complaint was a little biting sensitivity for some months. Pardon? It could be 9,000 things. Yeah. Angela says it could be the occlusion. Good. Who wants to retreat it? Apico, implant. This is all the same patient over time. What's that? Had she had the upper one dealt with? The answer is yes, just barely, because this is just a year later now. So the upper tooth's out. Okay. Some time goes by, a couple of more years, and she's back in 2008. She's got some chewing sensitivity, and her restorative dentist advised her that the root has a strange change to it. And so she's referred for tooth number 30. The root's got a strange change to it, he says. Tooth number, actually, I'm not going to give it away yet. She's clenching and grinding, and I advised her to wear her night guard over a month ago to see if that helps. Okay, so she had some sensitivity down here in this area as well. Just going through some of her teeth. Okay, a few more years go by. This is now 2013, and she comes back now, and she's acute. She's painful, she's swollen on this tooth. Nishan, where are you, buddy? Did Nishan come this time? He's going to be happy because guess what? This was the tooth that we saw in 2005 and didn't do anything with. So now it's blown up. So 2013. So she says that she's going through divorce, and that started about 1.5 years ago, and her dog died 1 year ago, and she's out of work, and she's been dealing with this, and she's not in a good financial place right now due to her divorce, and her husband is leaving her because she is a healer, and on and on and on and on and on. It's not a pretty sight.
So John.
Yes.
So go back to 2005. It's up there right now.
Yep.
So my mom and dad lived in Africa for 3 years in the bush. I mean, they were, and so if she came in before, she says, "Hey, we're going to Africa for 3 years," I'd retreat it.
It's thorny, isn't it? Yeah. She didn't say she was going to Africa, and where we are, where Scott used to practice with me. It's like, are you going to Antarctica? Yeah. Yeah, it's not clear. The decision making on 12 isn't clear, and it blew up some years later. Okay. So maybe I should have retreated it. Okay. All right. So she was in last week, and we got follow-ups on her. That's what that slide was. So I actually went back and got the restorative dentist's imaging. So we're going to get all of these answered. And as it turns out, I'm going to actually make the point that Rick and Gary made earlier today, unbeknownst to me that they were actually going to make that point. So here she is in 1988. And what a sad state of affairs this poor lady has turned into. So this is an old, scratched up, banged up pan. I did the best that I could to get it in there, but you can take a look at her. And basically she's got a few small restorations. The endo that's got gutta-percha insufficiency on tooth number 19 and a crown on that too. So that's what she looks like in 1988. Okay, so let's just kind of go back in time and see what we've got. So this is a couple of pieces of film, and this is around 1995, and we can see that she's starting to get some dentistry done on her. And she's about 40 now. So my hunch, I don't know. My hunch is she probably went in and said, "I want a new smile." I don't know. I'm guessing. Okay. So, and that's so long ago. It's like, can anybody really remember? So, illusion of memory. So we're going to just track this one quadrant over time. So here's this area in 1988, and we've got this mold that's just got a restoration in it, this bicuspid that looks like it's got a mesial and a distal restoration, and basically virgin anterior teeth, and we've got this endo down here that's at least 1988. It's done then. And my guess, actually, based on the history of where I practice, is this endo was actually probably done by the prosthodontist in town, maybe even 10 years before that. And so here she is in 1995, and we now can see that endo's on that bicuspid. And this guy down here is still trucking along, and now we see we got PFMs here, and there's endo on that tooth as well. 2001, things start coming unraveled. I was able to make a best guess that the endo on the upper molar, this guy, was done probably sometime in the very late 90s. For some reason or another, that didn't work out. An apico was done on both roots, and for some reason or another, that didn't work out. And a dB root amp was done in 2004, and you remember when I saw her on this was 2005. So I'm thinking this tooth went from here to here in a fairly short period of time, had a lot of treatment done. And guess who's still sitting there? Right? And guess who's still sitting there? Okay, so that's 2004, and there's 2005 when I got her for that particular quadrant. So this is kind of the tail of her dentistry and just kind of this one general area. Also, Berg, are you here? This is perhaps, you guys, I don't know if you can see if it shows on the screen, but this is probably one of the oldest dual access cases that I think I've seen. So she went from here to here in about 20 years. Yikes. Winston, what did you tell me? That's sad, or that's sorry, or something like that. So my hunch, again, because I did not see all of these things happen, my hunch is that we got some front teeth and some pulps died and some lateral incisors got reduced and then snapped off, and then we got a couple of implants up there as well. So this is 2007 on her. So this tooth that we saw in 2003. 2003, I was still an endodontist. I hadn't been out of my school, not out of endo for even 10 years yet, coming up on it. And I looked at this, and this is a one-tooth problem. I was suspicious of, given the history, that it was a vertical root fracture. And as it turned out, we started treatment and identified a vertical root fracture on the tooth. And that tooth is an implant now also. And today I might look at that, and I still might start a retreatment on that tooth because we just don't know. I've learned to not assume any tooth is cracked until I can see it. And there's very little downside. We're not doing anything to that tooth that has not been done before. It's an easy entry on that case. So I think that was I think I made a reasonable call there, and I would do it again. Yes? Pardon?
Just take cone beam, you'll see the fracture.
Yeah, right. I didn't have it then. 2005, we told her on tooth number 14, we told her to get that tooth out, and on tooth number 12, we didn't do anything. And we had showed some of the later imaging so you guys could see that as well. Okay, so that's the current situation on tooth number 14. So it's about a 10-year or so follow-up on the implant on that, and over 10 years on the implant on the lower bicuspid. 2006 was the first time that I saw her on this tooth with some symptoms on that tooth, and Angela nailed it. We adjusted the occlusion on that tooth, and her symptoms went away, and they've stayed away now. And I'm taking credit for a 30-year follow-up on that tooth by not redoing the endo on that. So you can see a little bit that the cusps are a little bit more blended flat here. Not a ton, but that's really all it took, and that tooth remains symptom-free for 10 years now. 2008, this one's an oops. So 2008, she came in with some symptoms in this general area and complained of some gum sensitivity, and this was the area where her general dentist said, the root looks a little strange in that area. And we thought she might have been getting food impaction, and we reviewed hygiene in the area, and she cleaned the area well, and her symptoms went away, but oops. So my guess is that she may have had that resorption. So this is 2008, and this is her pan from 2007 that I did not have. And maybe there's the beginning of some resorption there. It's a tougher call because that's a piece of pan that's been screen captured in, but I think that's actually what's been going on in that area. And in 2007, I would have done the exact same thing with it that we did when we discovered that actually in 2013, which was do nothing. She's not symptomatic. It's not bothering her. The only thing an intervention is going to do is make her worse. We've been following it for a few years now, and I think it's on the move. So there's the last week, so that's a 10-year follow-up from basically this initial spot right here where maybe we should have identified it back there. But she was referred for 30, and I looked at 30, and that was that. So I think that's one we missed, but I don't think there was any consequences to it because I don't think I would have done anything differently. All right. Yeah, we're getting there. So number 12, that's the one that's got, I think I would like to say, I hope has held your interest. So what do we do about 12? What should we have done in 2005 on this asymptomatic finding? That now we know has actually been there for at least 10 years. That tooth has had endo for at least 10 years because it was in the 95 bite wing. It's been completely asymptomatic the whole time. Treat, cure it, cure it, cure it. Pardon?
Education, educate the patient, something, give them warning signs of this thing's turning the corner to somewhere ominous, have them come in.
Yep. Well, it did turn the corner, became ominous. She came back. We had told her to do nothing at that time. I would just follow it, and we followed it. In 2013, she came back, and in my eyes, the radiolucency is clearly larger. Do I have any pushback on that? And she's actually acute, she's painful, and she's swollen as well. She's got a little swelling. And so what I did on that tooth was I adjusted the occlusion. What do you think? So 10 years ago, to me, that was the pattern of a vertical root fracture. What do you guys think about that? It's fine for a long time, and I have a history of going back 10 years, and now we know it's 20 years old, and then boom, all of a sudden it's got symptoms. What are you thinking? Who wants to do surgery? Who wants to retreat it? Who wants to take the tooth out? Remember, she's now doesn't have any money, her practice is falling apart, she's getting a divorce, her husband's cheating on her, her dog died. She's a mess. Did that. So this is actually not too long after we heard Slava, and we started talking about microbial dormancy and stochastic awakening and all that kind of stuff. So I'm thinking, I wonder. So who wants to see the 3-year follow-up from last week on this tooth?
Did you prescribe an antibiotic?
No. So this is from last week, and I'm claiming victory on a 20-year follow-up on that tooth from the occlusal adjustment. How many what? I'm sorry, Fiona, I can't hear you.
So how many of her original problems are caused by occlusion? Is that upper molar originally?
Yeah, why didn't you hit it? I don't know. We'd have to ask the board certified guy to the south of me. I don't know. So I'm glad you picked that up, because I think the role of occlusion in some of these problems that we end up redoing the endo on or retreating, I think the role of occlusion in parafunction. Rahim, are you going to talk about that? Yeah, he's nodding his head.
Sure, I'd like to.
Yeah, I think you are next year at the IAE, aren't you?
Yes.
Yeah. Okay, good. You are. So this has been a big awakening for me, and it explains, I think, a lot of what we see, that the patients find the endo's old, they go in, they get a new crown, and what one thing do we know happened? The occlusion changed, and all of a sudden they're sore. Yeah, so I flattened this puppy out, and we did short-term follow-ups on her, intermediate term and longer term, and this is staring right at 3 years now, follow-up.
So slide on the left, 2005, she has a lesion, that's what you want to call it.
I don't see a lesion, I see a radiolucency.
Slide on the right, the 2013, it's bigger. If she's not symptomatic, do you treat it?
Yeah. Okay, now we're getting to some good stuff. So I have a conversation with her. If she's not symptomatic, do you treat it? It's a little thornier, isn't it? So we got to get our heads around, we treat everything. Disease that matters that we can do something about, and disease that matters that we can do something about that provides a meaningful benefit to the patient. Okay, so there's a whole chain of inferential steps there that we've skipped. And it starts with looking at the radiograph and calling it a lesion. It starts with the definition of the specialty of our job is to prevent and cure AP. So this is a nuanced conversation. I have some of these that we've been following that have been enlarging. They're enlarging in an asymptomatic fashion. and it's not clear what to do, but it's also not clear what the outcomes of those are. It's absolutely not clear that intervening actually provides better outcomes for the patients, because she did not come in with the complaint of a periapical radiolucency back here. That was not a complaint of hers. She's fine. She knew it was there. She's a smart lady. She's educated. So it was a perfect person to do an experiment on. Plus, she didn't have any money then either in 2013. Sure.
I wish my occlusal adjustments were so successful, but what I don't understand is you got from a lesion to like, or a radiolucency to like a normal tooth, but in 2005, occlusion was probably fine, but there was still something at the apex.
Well, there's a better way to proceed, Ron, is there's always something at the apex, and what you see is a function of our ability to detect it.
Another thing, as an aside, at least in Holland, it's still considered malpractice to put a new crown on it to...
Well, we didn't put a new crown on it.
No, someone did between 2005 and 2013.
I don't know that they did. This is a piece of scanned film, and that's a digital radiograph, so I don't know that. Yeah. The post is there, still there. Dr. Doyen, you may speak to that question. How often did you place new crowns on asymptomatic, previously treated teeth and didn't ask the endodontist? How often did you do that in 20 years of practice? You never did. You said, I never asked the endodontist, right? I rest my case. So we only see them when there's a problem. We don't know all the ones that we don't see, that he does exactly what he did for 20 years and never asked the endodontist.
John, I just think, so we don't take the wrong message away from this and have all of you go back into your office and start adjusting occlusion. One of the reasons for having Costerton and Garth Ehrlich come out was there's a lesson in understanding chronic disease, biofilm diseases, and that lesson is that there is an ebb and a flow to chronic disease. And if you act when symptoms are the worst and they go away, you automatically think that it's because of what you did, when in reality it may have gone away by itself. Now maybe it had something to do with the occlusion, but it's a very complex system. It may have gone away whether he reduced the occlusion or not, or maybe the occlusion was just a very minor part of whatever was going on in her immune system that enabled her to deal with this. So I think Costerton's thing that there's an ebb and a flow to chronic disease, that we don't have the time frame to really have a good appreciation of that.
I have some imaging on her on the interim, and again, it's difficult to make the call with periapical radiography, but it looks like it moves up and down, and I have other cases like that too. This is just my most dramatic. So my take home is no treatment's always an option. No treatment may be the best option. No treatment is missing from our clinical trials. That imputes a 100% failure to the no treatment arms because they're not there. Just very coarsely, we have disease versus disease that matters. And every time we pick up a handpiece, there's a price. And we make many people worse. So that's my take home on that. She's so Sashi, right? Yeah. So what was the conversation I had with the patient at Christmas of 2013 when her daughter's in town and her whole life is melting? I said, your whole life's melting and you might just be grinding the heck out of this tooth, and maybe if we adjust the bite on this tooth and keep you from pummeling on it, this will settle down. And by the way, I heard some smart guy talk about microbiology, that there actually is an ebb and flow to some of these things, and maybe we get lucky. And by the way, you don't have any money either, and the worst outcome here is we take the tooth out. Okay. So that worked out well for her. I didn't charge her for it at all. So she knew that we were basically running an experiment on her. There was really no downside to it. The worst outcome was it didn't work, and we take the tooth out.
John, I'm assuming the driver of the direction you took was because the prosthetic worked on the tooth. In other words, if there was a small amount in that tooth, even if you had financial constraints, would you still have a few visits and just inclusion?
I wanted to run an experiment on it, and I got a willing subject. So if there had been a small amalgam in that tooth that might have tipped the equation a little bit, but still to present it in a balanced way, I really don't know that I could go in and predictably make this thing better in the asymptomatic case. In the symptomatic case, that's another story. And then it becomes, okay, how much damage are we going to do to the tooth in the process of trying to fix it? And it's not clear. It's just not clear.
Do you find you get caught out, like you have these frequent visits, so you adjust the occlusion, you're bringing her back to structured kind of a recall system, and you have decision. Do you find sometimes you do this, she's still swollen?
Yeah. I mean, if she'd come back and we did a 1 week, and then we did a 2 week, and then we did a 1 month, and then we did a 3 month, and a 6 month with a radiograph. So we followed her very closely for the first 6 months to keep a handle on this thing, because I don't know if this is going to work, and this one just happened to really go our way. So yeah.
If she were to come back again, if she were to come back again, let's say in another couple of years with symptoms and an increase in the finding size, what would you do?
So Fred, right? If she were to come back in a couple of years with symptoms and the finding had increased, what would I do? I'd have the exact same conversation, I think, today with her in 2 years, unless my thinking has changed then, which would be, we've got this dark spot up there, we've been staring at this thing, now it's acted up on us twice. Maybe there actually is something that we should go in there and do something about, or we can try what we've tried before that's worked and held you off for 3 years now, and however many years plus the time you're back as well. Yeah, and hope your life gets, and actually her life, she's back now. She's got a big smile on her face, lipstick on, hair's done, how's practice? I'm busy, how's life? It's good. So she's a happy girl now. She was a disaster back then, 2000 when I saw her first. So sorry, Gary.
Thanks, John.